On behalf of Ifso APC, I want to welcome you to the first debate in our session in Miami. Although all of us cannot make it to the meeting, we sincerely hope that the meeting goes well. And here we are, we're actually debating something we think that is quite important for bariatric surgeon. A lot of us doing bariatric surgery entering us because of their different specialty, their interests, and most of us are general and upper GI surgeons. And we inspired by the inspiration of our leaders to do this course to treat our patients to get rid of their metabolic problem. But when's the best time that we should join to learn for this surgery? And when do you think after about 20, 30 years of in this operation, when do we get sick of it? So today we have an esteemed panel to enlighten us so that all over the world can share our experience and learn from our elders, past and present. That's what we do in Australia now. When we open our meeting, we have to respect our elders. But again, we have a lot of up and coming stars as well. Without ado, I think we have two teams that is going to debate about each other's in terms of their view. We have the senior generations. We have two very esteemed surgeons that we're going to hear their point of view. And we also have our young up and coming star that's going to have a rebuttal. And then we have our panel, which we're going to ask them for their opinion and see who is winning. I think we will have Harry first. Harry need no introduction. He's a past president of all the society, and he's also the founding president for Ifso as well. So Harry, without disclosing your age, I would like to hear what you think about your journey as a bariatric surgeon.
Well, I sort of spent a lot of time, obviously, like most people, we all start off as general surgeons, but we started doing bariatric surgery. I think my first operation was back in 1974, which is probably before most of you were born. And I'm still operating, which is good. Not 5 days a week, but about 3.5 days a week. So that's good. What I've noticed over the years is that how the operations have changed and how things are different. How technically things are different. Scientifically, how we've analyzed surgery a lot more to the present day that we are. In relation, just briefly, to the age, and which is what we're going to see now, the discussion about. My overall feeling, obviously, as a senior surgeon who's still operating at an esteemed age, as you might say, is it's not the age, it's a number of other things which you'll hear about in a second.
Let's hear about your presentation now.
Hi. I'm Harry Frydenberg, and I'm the director of the Epworth Centre for Bariatric Surgery in Melbourne, Australia. And I'd like to join you in this debate on the age of commencement and the age of retirement for surgeons. The age of commencement. In Australia, at the time of the completion of the medical course, one becomes a surgeon after 5 years by completing 2 sets of exams. The first base is the basic sciences, anatomy, etc. And the second is the clinical and performance after 3 years of internship. And so at 29, I became actually a fully fledged surgeon. Now, people will ask, was this too early? I didn't think so, because I had already a good training and ongoing mentoring, which was essential in this process. Today in Australia, it takes much longer. Graduates become surgeons at about 34. Are they any better? Not really. No, as the training is more specific to certain specialties, and they're not thrown in the deep end like we were, in that we were doing all sorts of different operations sort of by ourselves and learning on the job, and a variety of things from burr holes to bowel cancer, whereas today the training is much more specific and much more towards a particular specialty. So what is the age to become a surgeon? Well, my overall feeling is that any age, as long as the training and the mentoring are up to standard. So what about the age of retirement? We're all getting a little bit older, some of us more so than others. And what influences retirement? First of all, age. 65 has always been considered as the traditional retirement age for most professionals and workers. But if there is a mandatory retirement age, it actually violates discrimination laws in the country. And in medicine, it also sidelines perfectly competent doctors and can lead to the workforce being undermanned. In 2015 in the USA, about 25% of doctors are over 65. And in 2017, about 122,000 doctors were over 65. Now, surgery obviously requires stamina, cognition, and fine motor skills. And these may decrease with age, but not uniformly across populations. And some learned tasks and physical memory are remarkably preserved over a period of time. This article is from the Journal of the American College of Surgeons. Now, surgeons have a cumulative wisdom and clinical experience of the senior surgeon. It's an invaluable asset that should be honoured and maintained. In relation to health, personal health issues may contribute to a decline of the cognitive and technical skills. Periodic medical evaluation is an essential part of the assessment, irrespective of the age. The Royal Australasian College of Surgeons mandates that or recommends all surgeons over 65 to have a personal GP, whereas Stanford University requires medical staff 75 or over to have physical examination, cognitive screening, and peer assessment of clinical performance every 2 years. In relation to performance, people say, well, I can do it, I know how I'm going, but self-evaluation may fail to recognise or deny diminishing skills. So peer evaluation by direct observation, clinical audits, continuing personal development may be the means of performance assessment. And just an example of direct observation, as you can see, on the left is being alert, doing the job, looking at the screen, where on the right, you may get a little bit lazy and fall asleep a little bit on the job. Financial security is also part of the process in relation to retirement. A systemic review from the Medical Journal of Australia of retirement planning by doctors found that continuing financial obligations delayed retirement, while strategies to mitigate career dissatisfaction, workplace frustration, and workload pressure supported their continuing practice. In other words, if you have developed strategies to cope with all these things like dissatisfaction and frustration, then you're more likely to continue on practicing. Doctors need to obtain financial advice and develop a financial plan from early in their career, particularly if they are self-employed. Relationships are another thing. A sense of responsibility to patients and the central role that a doctor plays may contribute to the consideration of retirement. In other words, if you feel that the patient can't do without you, if you feel that you're an essential part, it may stop you thinking about retirement. Also, if the medical career is central to your life compared to other roles, in other words, marriage or other intimate relationships, unless dealt with, may delay retirement, as the doctor may feel he needs to be relevant, and that makes him relevant in this career. And so it becomes an important aspect of his life. Lifestyle. Having alternate interests may also influence the age of retirement. Business, sport, research add to an individual's relevance once again, and thus the need to continue their surgical career may have less attraction with subsequent early retirement. But not having these, regardless of any age, may prolong a surgeon's career. In conclusion, age itself is not the determining factor in a surgeon retiring. Health, competence, peer review, ongoing education, relationships, financial security, all alternate interests, all come into consideration in regard to the age of the retirement of the surgeon. So stay happy, healthy, and competent, and you can choose when you want to retire. Don't wait till someone taps you on the shoulder. Thank you.
Thank you, Harry, for sharing the invaluable experience. I always find that every time um, we had meetings with Harry, he's able to share some of the wisdoms. So let's listen to our next speaker first before we have a debate. Our next speaker also need no introduction, is another giant in Ifso APC. We're very proud for him to be here, Professor Pradeep Chaubey. Not only he ran a very successful Ifso conference in India, he also was one of the founding pillars in Ifso APC as well. He himself also going to share his view in terms of being a senior surgeon, to give some tips to our younger surgeons on how to become bariatric surgeon and maybe when to actually become leader and maybe reduce the chance of operation. So I will let Professor Chaubey present first, and then we'll have a talk afterwards. We'll let the younger guys afterwards debate.
Thank you, Ken. Thank you very much. It's a real big honor, and also I would like to share my presentation here. Let's get the presentation, please. Hello, everyone. It's a great opportunity for me to be with you all again. And I've been given this responsibility to talk about the age of a bariatric surgeon. What is the right age? It's a very interesting topic, and I bring greetings from Max Institute, New Delhi, India. And as you know that the age criteria of age is very uh, personal, but I will just let me sort of move on. Uh, yes, so we talk about this is what I think the age means. Age is just a numerical, and I feel that everybody behaves differently at the different numericals. So age is no criteria. I think one should be physically and mentally fit, and that is what should be the criteria for any other surgeon. Now, very important is that at any age, especially when you are in a senior age, you should be working in an institution which has got the complete infrastructure support. Sometimes one gets retired and goes to the area and the hospital which does not have the support system. So that is not the right. Whatever may be your age, your infrastructure support should be there. And second, we always feel is that you have to keep on learning. It is not that what you learned 30 years back, because we are not born with the skill. The skill requirement for the surgeons keeps on increasing and also changing. So whatever is this state of art surgical practices and the protocols of that time, that is what you need to follow, and not to continue with your old traditions. Now, training is very important. Training is just ongoing process. It never stops. Every day you have to continue learning about the training. Decision making, I think for any surgeon, apart from the skill, it is important to have a proper and the right decision making. So if you are in a position to take right decisions, you can continue operating. Safety, I think every now and then you have to orient and reorient yourself with your own safety of your skill, safety of your decision making, which is important, unrelated with the number of years you are born with. Of course, the patients will expect you to be presentable, you to be under the control physically and mentally, and that is patient roles. Patient plays a very important role. So if you are physically alert, patient has got a confidence, of course you can continue uh, operating. Then comes the complication. If you feel that initially your complication rates were acceptable and off late something is going wrong and your complication rates are increasing, that means that there's something wrong. You have need to be re-evaluating your own skills, your own decisions, and of course the support system. But important another point is the legal and social issues of your country, of your city, of your state, of your society. What are the requirements? If you fall into that, maybe you can continue without any hesitation. And of course, getting the patient, as I discussed, whether you would like to practice or not, if your patient doesn't want you to practice or participate, that will be possibly a day when you hang your boots. Then we talk about the, sticking and bringing people together. So when you are young, you continue growing, you keep on getting your younger and younger colleagues. First, you are attached with the senior colleagues, and as you become senior, you continue your team, you collect younger people with you, and this is how you build a team, because team is the most important part in all aspects, and it is more true for bariatric surgery. So you should be the leader of the team, which should include the anesthesiologist and the physician, endocrinologist, psychologist, and whole lot of people with you. Many times we have seen that as you are growing up, you, instead of collecting your team, you keep on, deleting. You just fire somebody for for various reasons which may not be very justified. So at the end of your career, you find when you become serious, you have got hardly any team. So I think you have to be accommodative. Don't just use the button of delete and escape, and make sure that your team is with you. And of course, you have to keep safety. These here you see the two persons, one a driver and a passenger. So whatever you do, I think it will be your moral and your conscientious decision to take and continue your practice, and find out that your patient should be safe, and of course you also should be safe in operating. This is the world's oldest and the fittest 96% person, the Charlie Sylvester, which is there on the record, and he's doing marathon running and all the gym, whatever you are doing. So I would say cheer up, thumbs up. You can also be like him and continue your practice till you feel that you're mentally and physically you are correct, irrespective of the numerical figures, whatever you have. Thank you very much.
Very much. Thank you again, Professor Chaube. This is another talk that echoing what Harry has said, and definitely I'm sure we can learn a lot out of it. But I think now is time that we're turning to our young upcoming surgeon. We have two surgeons that is in our region that are up and coming, and not that he can share much about the journey, but I think he certainly can tell us their visions in terms of how they're entering into bariatric surgery and what's their plan. The first gentleman will be Jaideep Rao, and he's a hot shot, we call him, in Singapore, taking best selfie, best with technology, and his surgical skill is also already founded when he's a bariatric surgeon. So Jaideep, can you share your talk and tell us from your younger or more junior point of view to now, what do you think about bariatric surgery? When should we start?
Hello, everybody, and I would like to thank the organizers, Nathan Zundel and the Ifso committee, for inviting me to have this chat. It's truly a privilege to be here. It's unfortunate this COVID situation is there, but I hope we sort this out very soon. Thank you, Ken, for moderating this session, and it's great to have this topic here. What is the right age to become a bariatric surgeon, and what is the right age to retire? So, my mentor said 2% of surgeons are born gifted, 2% of surgeons just cannot make it, but the rest of the 96 can be trained. Now, the youngest surgeon in the world is this guy, Akrit Jaswal, who became the world's youngest surgeon at 7 years. Of course, he was not accredited. He was doing surgeries and posting it on YouTube, and he did the first surgery for burns victim who asked for him. And then he went to med school and became a doctor at 12. However, in the rest of the world, this may not be the case. And for example, in a country like Singapore, we have a very stringent training program. And usually post A levels, which is 10 plus 2, we get into medical school. We have 5 years of medical school. We do an internship of a year. Then we get into a residency program, which lasts for 7 years. We do a post-residency fellowship, which is 2 years before you become a specialist surgeon in bariatric surgery. Now, of course, this usually takes about 32 years when you become a bariatric surgeon at the earliest, but it could take longer depending on when you get into your residency program. Now, the key factors in practicing bariatric surgery is, of course, training and experience. The factors involving complexity in bariatric surgery, because bariatric surgery is a complex surgery. It needs mastery in laparoscopic suturing and stapling. It has also complex patients which are morbidly obese with multiple comorbidities, and they need a multidisciplinary care and experience. And therefore, a certain amount of experience is required before you become a competent bariatric surgery. And what is this? Mainly, this involves learning curve. You have a slow beginning, you have a steep acceleration phase, you have a plateau phase, and from a beginner to an expert, you undergo phases of the knowledge, comprehension, application, analysis, synthesis, and evaluation. And this takes a certain amount of time, but we want to reduce this as much as possible. So is this possible in young ages? The principles of this involve expertise, volume, standardizing procedures, and making this reproducible so that we shorten a learning curve. Usually learning curves is dependent on the structure of a training program, such as type of supervision and expert of the trainer. And of course, an increased number of complications in the learning curve is no longer acceptable. When we look at the learning curves in specialist centers, we look at the subspecialty training, we look at what is the center volume and the surgeon volume. All these will decrease the learning curve, and you can become a bariatric competent surgeon much faster. In general, laparoscopic gastric bypass is considered gold standard, and the learning curve is about 100 cases, as done by this lovely study by Phil Shower and Ikramuddin. Advanced laparoscopic does decrease your learning curve skills, and therefore, if you've had skills in other surgeries, this helps in learning curve. How to train residents to perform bypass, and there are CDs that can be done, like this study showed, and if you have good supervision, you can actually learn this much faster. A systematic review by Antonio Torres and group showed this. They looked at two groups. The first group, as you can see, they're all pioneers: Phil Shower, Scott Shikora, C.K. Huang, and these people started doing surgeries on their own without having any supervision. And the second group are younger surgeons that were doing surgery under supervision. And when they looked at the complications between the two groups, you can see that group one, that means the senior surgeons, had more complications because they were pioneers in the group and they never had supervision. What this tells us is that you can be a younger surgeon, but if you have good training, you can actually reduce the learning curve and reduce your complication. Skills acquisition in this is very important, and an innovative approach was done by some of my friends, Camilo Boza, Antonio Lacey, Aradarzi, and they developed a training program and an assessment tool for learning certain things that you require in a gastric bypass, a jejunal-jejunostomy models, and 16 inexperienced surgeons attended this task force to do these certain things. And they then tested on respective tissue, time and scale, etc., how you move during the surgery, enterotomy, stapling techniques, etc. And they found that the jejunal-jejunostomy model differentiated surgeons of varying experience. And when they translated this, you could see that those who did this model and training program before the course, you can see that these are young residents, and there was a big difference between them and the experts. But after the course, the trainees were almost as good as the surgeons. Again, going to show that even a young year one resident can perform these skills if trained in a correct manner. And A bariatric fellowship showed that you can actually decrease the learning curve and reduce your complications. And therefore, we won't look at how young can it be. You can be very young, and if you have a good training program, then you can be a good surgeon and can start at a very young age. Now, when should a surgeon retire? This was a New York Times article that looked at surgeons who are too old to operate, and some said 70 years is that. But a lot of surgeons have been unenthusiastic about this idea. And the reasons are these. We have to define relevant areas of aging and what this will affect surgical performance. Define current standards with respect to retirement across the globe, because we don't have a certain time or age across the globe to say when to retire. Define what is known about specific outcomes in regards to aging. If you look at these different countries, USA, no mandatory age, Canada, 65 years, Ireland, 65, UK, no mandatory age, Italy, no mandatory age, India, 65, Russia, China, 60 years, 55 for women. This is not based on evidence. So 50 to 70 years has been a statutory retirement age in many countries. But if you look at it nowadays, older surgeons are on the rise. There's increased life expectancy. In the US, 20,000 surgeons aged above 70 years. 19% of the surgeons in Australia are more than 65 years. 18% of surgeons in Canada are more than 65 years. And they looked at this study, which is a very CRASS study, which is cognitive changes and retirement among senior surgeons. And they looked at surgeons outperform age match controls in all age groups. And the decision for retire-based surgery should be based on skill level rather than age. Therefore, you need, after a certain age, to perform certain skills and get yourself accredited from time to time to make sure that you're competent. We're looking at psychomotor skills. More than 40% had similar to that of juniors, even when they were 70 years and older. And 78% had similar psychomotor skills of juniors between age to 60 and 65. So again, 50 to 70 age, we can't really tell what is that age, golden age to retire. It should be more structured. So when should we retire? Aging process in the brain affects surgical ability, yes, but considering individual variation exists considerable, and therefore it should be based on individual variations and so-called accreditation after a certain age. And a one age fits all model is not ideal for retirement policy. They should also focus, once people get older, say from 50, 60 years, then you start more on non-clinical roles, training roles, etc., because this can actually train young surgeons to be better and faster. What it took me 50 cases to become an expert, when I trained my junior, it took him 15 cases to be an expert, and these skills are transferable forward. So, of course, if you are young, like Harry or Pradeep Chobe, Harry Feinberg, he even beats us young people in tennis, in various other, in jogging, and he can still do surgery, and he can go on for maybe like this lady who's 90 years of age with no fatalities and doing 10,000 surgeries. But of course, we don't have all Harrys operating at 70, 80. And so we require it to be individual based before deciding when is that right time to retire. So thank you again for this wonderful chat, and we will again discuss during the time of discussion. Thank you very much. Thank you very much.
I love the fact that I think Jaydeep not only back it up with some scientific study, but he also pointed out to respect to our senior surgeon. I love it. That's how collegiate Ifso APC can be. Now, our next speaker is another up and coming staff in China. I think Hua Yang will be our young Ifso chair in next turn, and certainly in China, bariatric surgery has been taking off in big way for the last few years. So Hua, tell us what you think, what you plan to, and if we can play your slides, and then we can have a discussion afterwards. Now we have the full sets of decks of cards. So please go ahead.
Hi, dear friends. This is Dr. Hua Yang from the First of Lecture Hospital of Jinan University from China. It is my honor to be here today for the debate in the Ifso Apc session. The debate topic is about the age of commencement and retirement of bariatric surgeon. I would like to elaborate my points of view in the following parts. First of all, I would like to introduce you the role to be a bariatric surgeon in mainland China. Then I will share some literature review about the age of commencement and retirement for surgeon or bariatric surgeon. At last, I will conclude my presentation. In mainland China, if you want to be a bariatric surgeon, first of all, you have to spend 5 to 6 years to get your bachelor degree of medicine. After passing the board exam, and you can be work as a resident. But nowadays, if you only got a bachelor degree, it is very hard for you to find a job in big cities like in Guangzhou and other big cities in China. So we have to spend 3 years more to have our master degree of surgery after graduation, and you also can apply for a residency in some big hospital. But if you want to be more competitive, you have to spend 3 to 4 years to get a PhD degree. That is to do a research-based training in these few years, so you can get a PhD. And after that, if you are interested in doing research, you can have your postdoctoral training. That will spend you 3 to 4 years. So the higher degree you get, the easier for you to get a promotion in the future. So after 3 to 5 years residency training, you can be attending, and you will spend 5 or 10 years to become an associate and the chief. So, and if you are lucky enough or you are hardworking enough, you have a clinical background and also research background. And after that, you can be a clinical scientist if you can get some very good research and get some good paper published in some high impact factor journal. This is the way how we become a bariatric surgeon in mainland China. I mean the experienced and well-known surgeon, and also some of us may become a scientist as well. So based on the long journey I just mentioned in last slide, and in my opinion, the age of commencement should be as early as possible, especially in mainland China. We got huge case number in clinical practice, and even when we were students, for example, when we are starting the master degree of surgery, we got a lot of hands-on opportunities, which supervised and guided by our mentor. So try to get more experience when we were young. This study from the MBSA group shows that there's no differences observed in 13-day mortality between the surgical trainee and non-surgical trainee, but the surgical trainee patients had higher rates of post-operative DVT and and other post-operative complications. And this paper is about the surgical trainee impact on bariatric surgery safety. It shows that the fellow training has higher complication rate, but it is based on the trainee's level. One more paper is about training programs' influence in the learning curve. It shows that bariatric training mentored by an experienced bariatric surgeon may improve the outcomes, and that is why it is important to have senior surgeons, or what we call old surgeons, give us guidance during when we were trainees. So about the age of commencement, for the patient safety, we have to get sufficient training, a lot of training, as much as we can, and of course as early as possible. Now let's talk about the age of retirement. This table shows the retirement policy for doctors in different countries. Most of them are between 16 to 65 years old, but some countries don't even have any mandatory age of retirement. This paper was from JAMA. It shows that the older surgeons have more experience caring for patients, which need to be balanced with the potential impairment in their ability to provide high-quality surgical care because of age-related functional limitations. But when should surgeons retire? This paper suggests that the competence should be assessed individually, and we should focus on the functional ability of the surgeon rather than just the age. This paper is about physician scientists, or what we call clinical scientists. It is a good choice for the senior surgeon to become a scientist. It connects the biomedical science and the translation of research findings to clinical practice. So about the age of retirement, after you become a surgeon and later when you gain more experience, you will become a mentor. And of course, later you can also become a clinical scientist. So about the retirement, I think you can stay as long as you can. This is the conclusion of my presentation. The age of commencement, I think it should be as early as possible. And about the age of retirement, and as long as you can contribute and enlighten the young generation, I think you should stay as long as you can. And at last, I would like to take this opportunity to thank my two mentors. One is Professor C.C. Wang from Jinan University, and other is Professor Amy Xu from the University of Hong Kong for their guidance and for their support so many years. So thank you very much for your time.
Thank you, Wa. Let's have our discussion now. Now we have two sides of the story. It just showed that the immense depth of Ifso APC, I guess with all over the world as well, a lot of us have various experiences and various point of view. But tonight we're very grateful as well to have our three panelists, Kasama, and also Mufi, and also Ahmed Ali from Australia. So I'm going to ask each of you, give you some time to express your view as well. I think Mufi, you've been busy not being a bariatric surgeon. You have conquered the bariatric surgery. You've been our president before, and I think now you are turning your attention to COVID. But after listening to the two sides of story, what do you think will be the time for getting started with bariatric surgery, and when do you think we should kind of take it easy?
I think thank you, Ken. Anyways, it's really unfortunate that none of us could be together and hug each other like we normally do. And of course, let Harry or Jaideep host us for one of these crazy parties. And Ken, you were the one who used to lead us always. However, things will improve. As like they say, nothing lasts forever. Even the bad times won't last forever. And hopefully we shall all meet in Napoli very soon. But having said that, what I'd like to say is whether it's the old or young, as surgeons, I think we never seem to grow old. Like Harry, I think identifies, Professor Chobe is another one who identify that to the hilt. At the same time, you're never too young to perform a surgery once you're well trained. So we know with Jaideep, who's now the stellar surgeon in Singapore. And if any one of us wants to borrow some money, he's the man to go to. Wah has been leading the Young Ifso campaign in China and now more or less in Asia. He's one of the leaders. And I think that these guys give us hope that age is just a relative number. Yeah, whether you're too old or whether you're too young, it's only a matter of getting proper training. How soon you get trained, the earlier you become a thoroughbred bariatric surgeon. And once you become a thoroughbred bariatric surgeon, you never seem to retire, because there are people who are always going to come to you for your opinion when they're stuck into some kind of case. There are always going to be issues with bands that have not been removed, and Harry would be the kind of guy to go to, that this is what I've got stuck in, because this generation might not even see bands being placed. We also do know that, I think you asked me, when do you rest? I think I would rest only when I'm 6 feet under, because the entire life and journey till that point of time is a journey of learning. And I think as long as you enjoy what you're doing and you're passionate about your bariatric surgery or whatever surgery you're doing, I think it's only going to be a course wherein you keep enjoying yourself. And I think we've known that we've got the best of friends, from Harry to Wa. They're all very, very close friends of mine. So I think this debate is a great debate, but I think it's imperative to know that we need both sides of the coin to make it really one and to flip. Thank you so much, Ken.
Great work. I think that's kind of pretty much what I'm thinking. In fact, our next two panelists, if it's in real life now, I'll be actually not watching a debate. I'll be watching a real fight between Taekwondo and Muay Thai. Ahmed and Kazu are both well trained in those, and that's actually the real fight that we want to see. But I think let's give the next few minutes to Kazu first, being our previous well, still our present presidents, and handing over soon. Bit of relief and seeing the baton handing over to CC Huang, and I think we're leaving Ifso Apc in safe hand. But this is the spectrum and depth of bariatric surgery that we have. What do you think, Kazus?
Thank you, Ken, and thank you, Harry and Pradeep, for the insights from your areas. And also, I'm very glad to see that Jaideep and Wa is a very nice surgeon, and is they're one of the leaders in our area. So actually, in the end of last year, I was seriously thinking about retirement because of some accident. So I was diagnosed as a tumor in my hand, so that I was thinking of retirement. Fortunately, it was just a hematoma because of my karate and MMA. So I don't have to retire now, but I was thinking of retirement last year. Actually, that I'm doing a bariatric surgery for 20 years and being a medical doctor more than 30 years. And being a leader of Japan bariatric surgery for about 20 years, I think it's a time to pass my role to the next generation, like Yosuke and the other guys. But I'm still very interested in bariatric and metabolic surgery. There are many things to learn still, so that it's it's not easy to give up, to retire. But I think in someday I have to give my role to younger generation. That is a very difficult issue to us. And I think one of the important things to decision of retirement is eyesight, vision of surgeons. You know that when we did open surgery, the eyesight is one of the crucial things. But laparoscopic surgery can delay our age of retirement. So using a laparoscopic surgery, we can see much better open surgery in elder ages. So that I think retirement issue is really difficult to decide. But someday, in future, we need to decide. But at that time, we can do for that time we can think about when and how how to retirement is very important, I think, so that the give a lore to younger generation is one of the worst things to do for us as elder surgeons.
Thank you, Kazu. I think Ahmed is quite close to Harry. So Ahmed been our president in Australia before and also had trained numerous surgeons, and all the surgeons under him all do very well as well. But I don't think he's nearly as close to Harry in terms of thinking about retirement. But we all kind of label ourselves as middle-aged surgeons. But realistically, we can go this way or the other way. So Ahmed, what do you think of our two group of presenter? What would you do?
Thanks, Ken, and thanks to the presenters. I thought you guys all did a great job. It was really, really interesting. And like Mufi said, I wish we were all together face to face so we could do all the things that we always do. So I really miss you guys now when I see you here on the screen. And Ken, just for the record, with Kazu and I, yeah, sure, in the martial arts, it looks like we're fighting, but actually we're brothers. We're still friends at the end of it all. And I think this debate was like that as well. Actually, it wasn't so much a debate. Everyone seemed to agree largely that one of the key words was competence. And whether you talk about competence in a young surgeon being ready to practice, being competent because of their training, or you're talking about the older surgeon retaining their competence despite their age. So that age is not so much a factor at either end. It's more about training and competence, and something Mufi touched on, I think, passion as well. But I do want to just talk a little bit about competence, because how do we measure it? What are we actually measuring when we say competence? And one thing is outcome. Definitely that's important. From the patient's point of view, it's about outcome. Are they safe and are they getting effective outcomes? And we can demonstrate that. Surgeons are very good at keeping data and keeping their audits. So you should be able to self-reflect, whether you're young or at the older end, where your competence is standing. And it's a collegiate profession. We can always have our colleagues help. And this was sort of touched upon in all of those talks. So I want to approach it in a slightly different way. Jaideep, you brought up some really nice papers on the technical aspects of competence and showing that the learning curve for those technical aspects can be shortened if you give specific training. But I think the real value in the, if you like, the older surgeon is not really about the technical, because you're quite right, you can accelerate that learning. What is difficult to accelerate is the experience, because it's one thing to be able to execute something technically. It's another thing to make wise decisions and to recognize a wide variety of situations. That comes with experience. So there's some really interesting work looking at volume, surgery, volume relationships and safety. But the way it relates here is if you take young surgeons and place them with experienced surgeons in a collegiate unit, the outcomes of the young surgeons are as good as those of the experienced surgeons. But if you separate them, their outcomes are poorer. And what's being shared there is that collegiate wisdom, that cumulative experience that Harry mentioned, for example, because the older surgeon can tap the younger surgeon on the shoulder and say, oh, I know you're thinking about doing this in this patient, but I've seen this before. Just step back a little. I suggest you do this. And that's the thing that keeps them safe and accelerates their learning in that. So it's really about putting, I think Mufi put it beautifully. Many of the things Mufi expressed, I agree with completely. He put it really beautifully. It's the coming together. We need the energy and vibrancy of youth to bring excitement and energy, where sometimes older surgeons might start to feel a little bit stale, but the younger surgeons also need the experienced surgeon around to help tap them in the right direction when it's needed. And lastly, to Kazu, I agree. I mean, I suppose I'm not really thinking about retirement yet in any realistic way, but I am starting to think about the change in my role, because if you look at training in general, in any area, not just surgery, most of the data is pretty uniform. It shows that to become an expert, a true expert, takes about 10 years in any particular endeavor, because we're continuously learning. Mufi made that point. And even after we become experts, we're still learning, but we may be learning in different areas, in new ways. We may be getting better at mentoring or research or whatever else. So there's this opportunity for older students to continue to learn, to change their role, to still be involved, because really, once you're an expert, the technical side of it is kind of, yeah, that's just the technical side of it. Some of it's interesting, but mostly it's pretty straightforward. And we start to take an interest in those other things. So Kazoo, I don't think you have to turn it on or off. I think you can just change your role as you bring the younger surgeons through. So that were my thoughts, trying to sum up everybody's things together. But thank you very much, everyone. I really enjoyed that session.
Thank you. I think this probably is the most friendliest debate that we can ever have. It's highlight the fact that I think our big Asian Pacific family are probably different than what we saw in the big, huge fighting debate in the America. I guess for me is I guess last year I took a substantial time off work, and you're going from doing 50 cases to 0 and potentially staring at mortality. Then I think it makes you reflect and realize that, and step back a little bit and have time to stop and think about what's the future is like, and what is the generation changes. And you have to admit that sometimes we all do get wiser, we do get older, but maybe we don't get wiser. We have to actually have succession planning, and education is important. And all our speaker actually highlight a few important points. Our senior surgeon have the experience, our younger surgeon have the energy. When we add it all together and we can learn from each other, we can see ourselves either real life or virtually, we can share our experience, and together that's how we advance society, we advance a specialty. And I think we are probably time up now, but I want to thank our speaker for giving our time, although we cannot be together, but I'm 100% sure that 2022 will be better. But maybe I don't have a crystal ball, but let's hope so. Hope keep us alive, and let's hope that we can carry on and do our surgery and help other people. I want to thank all the speakers now, and we close this session. Thank you.
Thank you.
Thank you.
Thanks, Ken. Thanks, everyone.
Thanks everyone.
Bye.
Bye.
Take care.
Bye.
Hello, very welcome to the second session of Ifso APC. Greetings from across Asia. We would start our second session. The topic of debate today is chocolate versus smoking. What works for bariatric patients? We have eminent speakers today lined up to speak on the topic. To speak for smoking would be Dr. Ken Loy and Stephanie Gilroy. For the chocolate, so I hope at the end we don't land up eating chocolates, would be Professor Vijay Lee and Mariam Lakdawala. It's my great honor to introduce my speakers and my panelists for today. Our first speaker would be Dr. Ken Loy. Ken is a specialist upper GI surgeon who has an appointment with the St. George Public and Private Hospital. He's recently been nominated as the Master Surgeon in Metabolic and Bariatric Surgery. He's an active member of OSANS, Ifso Apc Session, has published very well and is very known among the bariatric community, both in Asia and globally. Stephanie Gilroy, she's a dietitian, has obtained her degree from King's College, University of London in 2000. She's working as a nutritionist and as a dietitian currently, and she's worked in different places with broad-based experience in managing bariatric patients. We have next off Professor Vijay Lee, who probably needs no introduction, and my brief introduction will not do justice to him. Having said that, he is a pioneer and researcher in the field of bariatric and metabolic surgery in Asia. He is well known globally for his ABCD scores, setting up the Asian Diabetic Surgery Summit. He's published over 300 peer-reviewed papers in the field of bariatric and metabolic surgery, and he currently is going to be us speaking on chocolate. Ms. Mariam Lakdawala, she is also a nutritionist, a dietitian who's got her master's in food and nutrition. She's basically a yoga trainer as well, which is quite interesting. And she super subspecializes in the field of bariatric nutrition. So it will be interesting to hear. I have great panelists with me. First off, I have our incoming president for the Ifso APC chapter, Professor C.C. Wang, who's currently the president of the Chinese Society for Metabolic and Bariatric Surgery. He is very well published. He started the first Chinese journal about clinical and basic research for metabolic and bariatric surgery. He's authored many papers and is probably one of the highest numbered bariatric surgeons in China. We have Dr. Tam Kong Wei. She is well known across the APC chapter, a standing endocrinologist, probably the only endocrinologist we've got today here, and she leads the Ifso APC Allied Healthcare as the vice chair, along with Don Dixon leading the chair. Her main interests are bariatric and metabolic surgery, as well as an endocrinologist. She set up the center that was at Singapore General Hospital, the obesity and metabolic unit. She's also the president of SASO at the moment, which is an association for the study of obesity in Singapore, and she is well versed with the workings of the World Obesity Federation, whom she is a member of. Last but not the least, we have our immediate past president for APMBSS, Dr. Simon Lau, who is a Simon Wong, sorry, who is a consultant surgeon in the upper gastrointestinal and metabolic surgery division of Prince of Wales Hospital. He is also with the Chinese University of Hong Kong, and he is very well published. He's currently the president of the Hong Kong Association for Study of Obesity and Hong Kong Society for Bariatric and Metabolic Surgery as well. Loved your papers on the cost effectiveness that comes from Asia. So we've got a great panel and we look forward to a great program. So I hope we have a great session. I would like to invite our first speaker, Ken Lloyd, to please load his presentation.
Thank you, Asim, for the introduction, and hopefully we can share some experience or what our thought on smoking is. Welcome to the debate about smoking in bariatric surgery versus chocolate in our Ifso APC sessions. Apologize cannot attend in person, but hopefully we can have some discussions regarding of the following sessions, whether smoking or chocolate eating is worse in our bariatric patients. I suspect that we have to frame the question first. The main thing we're going to discuss about is cigarette smoking, possibly vaping, the effect on our patients, and also potentially for our Middle East colleagues on Habli Babib and also the shisha. We're not going to discuss about substance using such as marijuana. I think it's been well documented that smoking associated with quite a lot of surgical complication, not only just in bariatric disease, but cardiac issues and hernia problem. And it's concerning enough that when we're doing our systematic review by the Canada group last year in SAGES, they found quite a fair amount of study that satisfy the criteria to look at, especially longitudinal study on follow-up to demonstrate the problems associated with smoking. And this is in terms of mortality and complications, particularly wound problems and pulmonary complications. And all those reports demonstrated that there is a vast association between smoking and worse outcome. From surgeons' point of view, we're of course concerned about surgical complications. We always try to ask our patient to stop smoking before any form of surgery if possible. This is part of public health that we've been doing that for a long time, and we've been doing that successfully and leading towards not the demise, but at least the awareness of smoking associated with health problems in lung cancer, etc. But there's a strong association between smoking with patients with death, because we're dealing with particularly our bariatric patients who already had quite a high degree of metabolic problems and potentially complications associated with stroke, myocardial infarctions, DVT, PE, wound infection, and pneumonia. All these can affect directly the outcome and also the mortality of the patient as well. And in 2021, lately, we also showed that they staying longer in hospitals and have higher chances of readmission rate. And I guess also not only affecting long-term wise about surgical complications such as marginal ulcers in bypass surgery, it affects metabolic absorptions of calcium and vitamin, leading to bone fracture, which I'm sure Stephanie will operate. And when they use large population study to look at the NESQIP data on 13,000 patients undergoing bariatric surgery, they identified 10% of them were smokers. And when they follow up their outcome, they found statistically substantial difference in terms of death, wound problems, and respiratory issue. All these are associated with longer length of stay and potentially can negate the effect that the patient will benefit from in terms of weight loss and resolution of comorbidity. This is particularly associated with gastric bypass operation, which for American has been doing that for a long time. And when they try to apply to look at sleeve gastrectomy, as we know, sleeve gastrectomy now is probably the world's still the most common operation now in all the different continents. Cleveland Clinic tried to see if patients who smoke, is there any contraindication for them to have sleeve gastrectomy? Because on one hand, sleeve gastrectomy is relatively simple and easy to perform. But if patient who smoke leading towards more adverse event, then patient need to be discussed with. And sure enough, they do find that, again, the morbidity events and mortality are slightly higher, and it's actually statistically significant. But not to the state that they would counsel or not offer the patient who smoke to have sleeve gastrectomy, but they should, at least for the sake of reducing perioperative complication, to stop smoking before surgery and potentially afterwards to ensure that healing takes place. Because as we are aware that healing not only requires food, nutrition, and good surgical skill, but also oxygen, which smoking has been in smokers has been reduced. And particularly my anesthetist told me that in terms of anesthetic issues like reintubation, laryngospasm, and pulmonary edema even are higher in smoker. And also because of a lot of the chemicals that is in cigarette, the cytochrome P450 are particularly affected, which alters pharmacokinetic of potential drugs, painkillers, anesthetic medications administration, and also raise carboxyhemoglobin, again affecting oxygen's permeation to tissues to enhance healing. And some patients say that, or they remember that when they smoke, they always lose weight. And when they actually don't smoke, they put on weight. So a lot of them do went back to smoking despite the fact that they stopped for a little while because they trying to lead a healthier lifestyle and hence they want to have bariatric surgery. But I think unfortunately for those who utilizing the theories, sadly speaking, there may be only 3% of excess weight difference in long-term follow-up, which probably not worth the detrimental health effect that smokers will suffer from. So I look forward to listen to my other speakers and
have a bit of look into with in terms of dietetic review as well on the rate that smoker affecting in our bariatric populations, and we have a discussion afterwards. Thank you very much.
Well, thank you very much, Ken, for that lovely talk. We'll move on to Stephanie Gilroy for her talk. Stephanie, over to you.
Dietitian at St George Private Hospital, working with Dr. Ken Loy. I'm also a clinical lecturer at Macquarie University in Sydney, Australia. Thank you to the organisers for inviting me to debate today on the topic of smoking versus chocolate, what's worse for bariatric patients. So I'm here to argue that smoking is worse than chocolate from a nutritional point of view. So smoking allows a toxic blend of poisons and cancer-causing chemicals to enter the body and put our internal organs at risk. Smoking creates an abundance of free radicals, causing oxidative stress that can cause cellular damage and deplete essential vitamins and minerals in our bodies. Smoking also increases the risk of gum disease, tooth loss, and also tooth sensitivity. And once a person has gum damage, smoking can make it harder for their gums to heal. Smoking supplies the brain with nicotine, altering and suppressing a smoker's ability to taste flavours. The reduced oxygen supply from inhaling tobacco smoke contributes to the dulling flavor recognition in the mouth. Smoking irritates the nasal passages, which can cause inflammation and impair the sense of smell, and this can influence the pleasure of eating. Nicotine suppresses appetite because of its effect on the brain and the central nervous system. Vitamin K helps to make various proteins that are needed for blood clotting and the building of bones. McEwen and colleagues noted that male smokers had lower plasma vitamin K levels than non-smokers. There's a negative association that was found between smoking and proteins induced by vitamin K absence factor 2 by Yuang and colleagues in 2015. Vitamin C is a water-soluble vitamin, and so it's unable to be stored in the body, unlike vitamins A, D, E, and K. So we must get vitamin C from the foods that we eat each day. Vitamin C is needed to make collagen, a protein which is responsible for growing and repairing cells in our bodies that produce skin, muscle, ligaments, and blood vessels. It helps to keep our immune system strong and reduces blood sugar levels. And it also has the unique quality of being able to help with the regeneration of other antioxidants such as vitamin E. Studies have found that people who smoke and those who are also exposed to secondhand smoke have reduced amounts of vitamin C in their bodies. Smokers require more vitamin C per day than non-smokers. Lickersfeld and colleagues demonstrated plasma vitamin C concentrations are reduced by up to 40% in male smokers. They then corrected for intake of fruits and vegetables, finding smokers still had lower plasma ascorbate than their non-smoking counterparts. Kalner and colleagues also noted that the metabolic turnover of ascorbate is markedly accelerated in smokers. As smoking is a known factor for contributing to bone loss, smoking may interact with 25-hydroxylase in the liver leading to reduced levels of 25-hydroxyvitamin D. Less vitamin D absorption leads to less calcium available to strengthen bones. In our sleeve cohort at St George Private Hospital, we found that almost half of our patient group had pre-existing vitamin D deficiency. We didn't at the time look at how many of those were smokers, unfortunately. Smoking is a risk factor for osteoporosis and in women may result in early menopause compared to a non-smoker. Vitamin E is an important nutrient that helps us to build red blood cells and bolsters the immune system to fight off viruses and bacteria. Like vitamin C, smoking appears to increase vitamin E requirements. Vitamin E is one of the first lines of defense against the free radical damage to the lungs when we breathe in air pollution and cigarette smoke. So to conclude, at present, there's limited literature examining the association between nutritional deficiencies and smoking following bariatric surgery, so further work is needed in this area. However, the nutritional status in smokers may be further compromised by an inadequate diet, and studies show that smokers are less likely to consume fruits and vegetables. Smoking a pack of cigarettes a day costs about 100 Australian dollars a week, and spending on cigarettes may mean less money for essentials like good quality food. Based on the current information, it's too early to state that the antioxidant vitamin supplements are certain to prevent or ameliorate the overall tissue damage caused by cigarette smoke. Thank you.
Thank you very much, Stephanie, for that lovely presentation. And we will move on now to Professor Wijeli, who's going to talk about chocolate is worse compared to smoking for post-bariatric patients. So Professor Wijeli, over to you.
Hello, everyone. I'm Wijeli from Taiwan. I'm very happy to join this interesting debate. My job is to debate which one is worse, chocolate or smoking. And I'm speaking about chocolate is worse. Of course, chocolate is worse because chocolate may ruin your surgery, which you should take the responsibility. And smoking may jeopardize the patient's life, but that is his or her choice. So we already have the answer, right? So now I'm trying to explain more detail. So I will look at the background and primary goal and treatment. So the background is why it is bad, chocolate and smoking. Because I think chocolate may decrease weight loss because the patient loses of the control of his or her eating. And that is not a good sign of bariatric surgery. And the sweet may cause dumping syndrome and decrease the diabetes remission. That is why it is bad for bariatric metabolic surgery. And for smoking, I think the most important risk is marginal ulcer after gastric bypass. It's about 10 times risk compared to non-smoker. and may also increase some GERD symptom. And of course, smoking is many cancer risk factor for many cancers, so it is bad for the patient. And we need to look at what is the primary goal of bariatric metabolic surgery. If we look at so many clinical trials, I think the most important outcome for any bariatric metabolic surgery is weight control. Then some study may look at the diabetes remission. As far as I know, there's several studies look at hypertension and sleep apnea, and may have some other comorbidity. This is a primary goal, so we should look first upon this. And the secondary goal usually is the surgical risk, long-term complication or quality of life, and this may relate to smoking. And primary goal is always related to chocolate. So which one is important? I think the answer is clear. And the last is about the treatment. Once you have a complication after chocolate or smoking, how do we treat? For weight regain, I think there are several options from lifestyle modification, medication, endoscopic procedure, but I don't think it is a good effect. And about surgery, it's also very difficult, and the result is usually not so satisfactory. So it's difficult to treat. And for marginal ulcer, I think we have a good medication like PPU. It's quite effective to control the symptom. And for intractable marginal ulcer, we can do revision surgery plus the truncovagotomy. In my personal experience, it's quite effective. So which one is easier to treatment? I think the complication after smoking is easier than the chocolate to be treated. So my conclusion is quite simple. Of course, chocolate is worse because chocolate may ruin your surgery, which you should take the responsibility, and it is difficult to treat. And for smoking, of course, it may jeopardize the patient's life, but that is his or her choice, and the treatment is easier than weight regain. So in a surgeon's perspective, I think chocolate is worse than smoking for bariatric metabolic surgery. So thank you very much. That is my debate. Hope to see you soon.
Well, thank you very much, Professor Vijay. Seems like chocolate, what we love, all of us love a lot, may not be the best thing to take, but we should come back to the table to discuss further. Mariam, we would like to hear your thoughts about chocolate. I do hope you can sway away a little bit from Professor Vijay's and allow us a little bit of chocolate, our patients to enjoy some quality of life. So look forward to hearing you, Mariam.
Hello everyone, my name is Mariam Lakrawala. I'm a registered dietitian and a bariatric nutritionist from India. So today I'm going to be talking about how chocolate can be worst for patients, for bariatric patients. And though I'm not going to be telling that it's going to be worse than smoking, because like smoking, chocolate consumption can actually choke. So, chocolate, when we think about chocolate, it is actually known to be an indulgent. You generally would consume chocolate to feel better, to become little happier if you're sad. So, chocolate is actually considered to be a very rich food that elevates mood. So, before we talk about what could be the harmful effects, I would like to highlight what exactly chocolate consists of. So, it basically consists of the cocoa solids and the cocoa butter. And the cocoa solids is the one which is the healthy part, which contains all the vitamins, minerals, fibers, and polyphenols. And these cocoa solids are present in more quantities within dark chocolate, that is more than 35%, compared to the milk chocolates, which are commonly consumed by almost half of the population, which prefers milk chocolate. The content is only 10 to 12%. Now, as I said, that the cocoa content is mainly responsible for various health benefits that we think when we think of chocolates. That is, it helps in the cardiovascular health, brain health, immune function, skin, cognition, etc. However, during the process of making chocolates, the processing itself makes most of the cocoa not very available. Also, generally, these chocolates have a very high content of sugar, which sort of neutralizes the benefits. It's a very energy dense food. Mostly the calorie content is more than 500, mainly because of the high fat content. And these factors actually make chocolate a potential threat to health, especially in the population that suffers from obesity. So, what are some of the harmful effects of chocolate that we see in the post-bariatric patients? So, chocolate has shown to increase acid reflux, mainly because the cocoa in chocolate causes the esophageal sphincter to relax because of the serotonin release, which could cause the gastric contents to come up. The caffeine and theobromine in chocolates could also trigger the acid reflux. Because chocolates are high in sugar and fat, it can lead to dumping syndrome, wherein the food gets dumped and then the patient experiences various symptoms, early and late dumping symptoms, including nausea, vomiting, drop in the sugars. And definitely hypoglycemia also is commonly seen. And this is mainly due to the sugar and fat content of the chocolate. And as I said earlier, the energy density, which over a period of time can definitely lead to weight gain. One more thing that is commonly seen is addiction transfer. So there is a lot of stress that the patient undergoes even after surgery, because there are a lot of adjustment issues with the body, with the food, eating behaviors, the stress of losing weight, which is very constantly playing on their head. There could be also history of mental trauma or issues, inadequate support from the family, loneliness. All these things is constantly puts them under pressure and stress, and there is a tendency to replace one compulsive behavior with another. So many a times they know that things like smoking could lead to ulcer formation and could be very hazardous to health, so they think of maybe relying on foods because they feel that would be a safer bet. And definitely more the consumption of chocolate, more will be an increase in the cravings, and it could also become habit forming, which gradually leads to weight regain. Also, it is seen that people suffering from obesity have a faulty neuroendocrine mechanism. They have shown to have an overactive response to one of the stress mechanisms of the limbic hypothalamus pituitary adrenal axis, and this overactivity lowers the serotonin level and causes a change in the brain chemistry. Now, this change in the brain chemistry increases the cravings for carbohydrates, fats, increases appetite, decreases satiety, and sugar and fat coupled with taste and smell causes a stimulates the dopaminergic activities or the reward system in the brain, producing feelings of happiness and joy, which sort of is produced similarly with substances like nicotine, cocaine, or alcohol. So now, over a period of time, the low levels of serotonin and the enhanced LHPA activities, what it does it is downregulates or blunts the dopaminergic response to the stimuli, and this further in turn causes increased dependence on food, and there is further increased cravings and increased consumption, and this all has an adverse long-term effect eventually. So yes, since weight regain is something that is perceived as the biggest health concern post bariatric surgery by patients undergoing bariatric surgery, because that is what they've been suffering with all their life. So when they start seeing weight regain, the fear of weight regain is very, very big, and thus definitely frequent consumption and too much consumption of chocolate can lead to worst weight loss outcomes post bariatric surgery. So I would say that the plan of action for every bariatric surgery team should be to identify whether pre-operatively the patient is having any food or substance addiction, to then identify the cause if there is, with the help of a psychologist, to also help them with coping strategies, because this kind of approach will thus favor the best outcome post bariatric surgery. So like I said in the beginning, um, chocolate exactly would, it would choke you like a smoke. So definitely chocolate is a worst thing post bariatric surgery. Thank you.
Thank you very much. Thank you very much, Mariam. Can I call on my panelists and the great speakers to be out here with us? Thank you. Lovely. I'll wait for the rest of everybody to come online. Right. So, all right. For the smoking team, I think while everybody's coming online, Ken and Stephanie, smoking suppresses appetite. You know, post surgery, you go for a smoke, it's going to suppress my appetite. Isn't that a great outcome you want our patients? With hearing weight regain on Mariam's side, and here Steph was telling you can make them lose weight. Why not allow smoking then? What's your take there?
Well, in fact, I think, Asim, you're right. I think in old traditional British surgery, isn't it? Everyone after surgery, they go to the smoking lounge in the gentleman lodge to smoke cigar. But
Yeah.
I haven't sort of say about the fun fact of smoking. I guess both of the substance of addiction, and nicotine is actually very resembling acetylcholine, which bind to the serotonin receptors and hence addiction. One cigarette got 1 to about 18 or 12 milligram of nicotine, and the absorption is variable. So to be honest, the definition of smoking, we all need to know. Heavy smoker means you smoke every day. Light smoker are actually the one that smoke once a week. And if you smoke few times a week, you call medium. So most patients come to you saying that I don't smoke very heavy. I smoke a couple of cigarettes a day. They are heavy smoker to definitions. And I guess it's not the nicotine that I'm concerned. There's about 77,000 chemicals, and all of the chemicals, butane, aerosine, and all the trace elements and toxic biochemistry that interfering with the body metabolism. That's the one that I'm worried about. They reduce the carbohydrate protections from pancreas and duodenal mucosa, which that's why people get ulcerations. And so that's the focus of it. But I guess both of them are equally bad. It's just that smoking already been flagged, whereas chocolate is still very legally well sell substance that we can get every day.
Lovely. Thank you very much. So I think in a subtle way, Ken has also said light smokers once in a while, a cigar, a shot isn't bad. So, okay. All right. Over to Simon Conway. What do you guys think? Do you have any questions for the esteemed speakers here? Simon? All right. I think while we wait for Simon to get his voice in, Conway, what do you think? Do you have any ideas, any hot opinions? Why would you share your thoughts on this?
Yeah, I think actually one interesting thing is, a lot of patients actually stop smoking before surgery because you guys tell them the risks and they're motivated for a short period of time. But as Ken has pointed out, it's an addiction, right? So, I mean, we've taken away the pleasure and addiction of food, and often they need to replace. So I think, do we know actually the incidence of people picking up smoking again after surgery?
Is there data?
The re-smoking rate is actually quite high in a lot of the study, and doesn't matter how promising they are. I mean, we're not as organized as the hernia society. I think Simon and a lot of us, we do a lot of hernia. The Carolina score, the CEDAR app, actually smoking is one of the documented risk factor for complication. And I'm sure you heard that cardiothoracic surgeon often refuse to operate on patient based on the fact that they have smoke, and the nicotine actually hang around in the body, can be detected in urine for a couple of months. So they want to wait until that is clear before they offer surgery.
Simon, do you want to ask any question? I can't hear you, Simon.
And he used.
All right. Okay, Simon, you can type and I can do a brief for you out from there. My question to both of them, then that means we can't tell our patients to smoke. We can't tell our patients to eat chocolate. Guys, where's the fun in life? You told them you have great fun. You'll become active. You know, the healthy part lives in the mind for a while. But where is that human being that comes in the person? How do you deal with that human being?
I think it depending on the compliance of patient, isn't it? I think Professor Lee probably dealing with patients that are more compliant, being Asian patient, they respect their doctor, especially with Professor Lee. Professor Lee say one word, we listen. So my patients are more diverse from different cultural background, and they often like to do what they wanted, despite Stephanie and us encouraged, and we can only try our best. But I mean, we all have the good intention for the patient to do well. So we know what they should not do, but I think we can only encourage them with the fact, isn't it? I believe in India also, I think there is a cultural thing about food enjoyment and get together with family. So often, you know, center on food and gathering. And when food gathering, there's only alcohol, food, and smoke that brings people together, isn't it?
Yeah. Yeah. So Simon has got a question for our smoking guys. So he says, is there any evidence that actually smoking reduces weight loss?
I think you replace when you smoke, you can't eat.
Yeah. So
it's like
so it actually improves weight loss on the other hand, but Ken is just defending it so that on the other hand, people don't start smoking and hurting themselves. You know, Stephanie, I do agree that it actually results in a lot of malabsorption of vitamins, but you can always overdose the patients a little bit with their vitamins, right? So we can always catch up somewhere with that. What do you think on that, Stephanie?
You muted.
Okay, one moment.
Yeah, we can hear you well.
You can hear me? Okay. So certainly we encourage all our patients to adhere to a lifelong multivitamin and mineral supplementation post-bariatric surgery. And we review their bloods on a regular basis just to make sure that they're not becoming complete in any particular vitamin and mineral deficiencies. But what we often find is that adherence to the multivitamin and mineral protocol does again wane with time. And what we're really trying to promote is diet quality through good quality varied diet, and really focus on that as our sort of primary education with the backup of the supplement. Most foods have a better bioavailability when they're eaten rather than consumed as a supplement, with the exception probably of folic acid, is actually better absorbed in the supplement. And of course, vitamin D, as we noted with our cohort, it's very, very common preoperatively. So we do obviously need to encourage that on an ongoing basis as well.
Thank you. Thanks, Stephanie. Dr. Conway, do you have any other questions for our panelists?
I guess for the chocolate group, I would say that, you know, it's such a specific food. So how, I mean, you eat a variety of food. I mean, how are you going to delineate, like say one food is going to have that impact on health? You know, it could be the amount of chocolate, and then maybe they're eating antioxidant foods, and that could have counterbalanced that. So how do you actually justify your stand in that sense?
Can you hear me?
Yes, Simon.
Okay, finally. I want to ask our dietitians, have they ever seen a patient after bariatric surgery can still eat a lot of chocolate or a lot of sweets. I think after surgery, the surgery did the thing is that they will change your taste, and also you're unable to eat such amount of sweets. Is that true?
It probably depends on the type of surgery. So perhaps with the sleeve patients, they may not be as susceptible to the dumping syndrome compared to, say, the gastric bypass patients. I'm not sure if you would agree with that, Mariam, but I think it probably partly depends on the surgery. But often where there's a will, there's a way, and people will find a will. And I think when we think about our cohort of patients, I guess the majority of people who are having surgery are women in their kind of 30s to 50s, perhaps. That age group is a very common group who have the surgery, and trying to take chocolate away from that age group of women is easier said than done.
Yeah, I agree. Mariam, do you have any comments?
Yes, I do have actually a couple of patients. In fact, one of my patient has undergone a RYGB, and after 6 months, he started eating so much of chocolate, and he was so dependent on it that he used to actually try and manipulate by having the protein shake first and then the chocolate, so that he doesn't get dumping. So he did this manipulation all by his own. And until now, he tells me that this is something I can't give up on. And he is maintaining his weight also, by making sure he's not having other bad carbohydrates. And also he works out. So he's able to manage it. But like Dr. Ken said, that the compliance is not a problem. In India, the compliance is a very big problem. So if we allow them saying that, okay, once a week you can eat, they would go on to eating more frequently and actually on a daily basis as well. And that goes totally not really noticed to us.
But I
see.
Yeah,
Can
please
I
go.
have
Yes, please. Yes,
yes.
Professor Vijay.
I think to be fair with this argue, I think maybe we can say smoking is bad for bypass procedure. I see difference, and the chocolate is bad for the sleep. So that will be fair for a procedure, I think. Yes.
Okay,
I do agree. I think I understand Professor Lee's point, because smoking has been always documented as bad thing. So if the patient choose to smoke, it is their problem. We can smell a smoker from far away, but we cannot smell a chocolate eater. They will always tell you, I have 1 or 2 pieces of dark chocolate, and you think it's okay, but we don't know how much they have usually. If the surgery doesn't work, it's always the surgeon's fault.
So if Mariam, you said chocolate, actually it's not cocoa, right? You said the cocoa is actually quite good, right? It's the fat, it's the sugar in it that's bad, right? So now what do you think about 90% cocoa chocolates? What do you think about the 50-60%? They don't have that much cream in it, they don't have sugars in it. Would that be okay? Would you say yes to your patient? If I told you I want a 90% chocolate, can I go and have a brownie that has 90% chocolate? Is that right with you? Just cocoa?
Yeah, I mean, if it's a dark chocolate with 90% cocoa, I would say, okay, you can have that. But I'm sure that the preference for milk chocolate is quite higher, because obviously it's tasty compared to bitter chocolate because it has no sugar completely. So many would not really buy that point. But yeah, there are many, I mean, dark chocolate consumption has picked up a lot in India actually, because they feel that it has a lot of benefits, and they can have that instead of the milk chocolate. They can relish it on a daily basis. So actually the consumption has gone up quite a bit.
Cocoa with stevia. Is that a good solution?
Yeah, it's a good solution, but again, stevia also leaves a lot of aftertaste. So, people who already have that taste memory, they will not really accept it.
Okay.
But obviously, it's what we advise them. That's the only alternative we have.
And I think
cigarette without nicotine and electric cigarette without the carbon. Is that good enough? Shall we do that? What do you think? What are your thoughts on that, Ken?
Well, I guess if you have look at the data from the our MINEC society, the rate of perforations and marginal ulcer rate are much higher compared to a lot of countries, because I partly noticed that it's actually the concentration of nicotine and chemical in shisha and those called recreational smokes. So I think that definitely is something that we notice even in our Australia, in our Middle East patients cohort. So definitely there's something to deal with what they do as a cultural thing relative to smoking. So I mean, there probably should be some study doing that. But I reckon next time we do the debate, we need to throw in another arms of debate called alcohol. That will really mess things up, I think.
Yes, that's absolutely right. I think we will soon be coming to the end of this program. But before I go and we close the session, I'll start with Mariam first for some closing remarks. Mariam, to you.
So definitely there is no comparison between a food and a substance, but because weight regain, I said that is like something that people dread who've already undergone surgery. So keeping them away from these foods by counseling them from time to time and telling them that it can be avoided and it can definitely be consumed in moderation. Like moderation is the key to have the best weight loss outcomes post bariatric surgery.
Thank you. Stephanie.
Thank you. I think I'd like to add the importance of mindful eating, and particularly if you are having something such as chocolate, just to really enjoy it. But it's about quality, not quantity, and perhaps it's about context as well. So yeah, I think I concur with Marian's comments about the importance of sort of that good quality education and ongoing support.
Thank you. Dr. Kongwei. Do you have any comments?
Yeah, I guess the whole thing about diet is very difficult. I guess it's a reflection. If someone loves chocolate that much, it's probably maybe a reflection of a kind of addiction association with that, and poor quality diets, which actually is the key. I mean, it's been shown in the global burden of disease. There's a very good study. It looked at so many types of diets in 185 countries that actually it's the quality of food, like grains, low in grains and saturated fat and high salt. So it could be a reflection of other things. And to me, smoking, honestly, it's more than just the nicotine. It's a lot of pollutants, and it doesn't just affect the person; it also affects the people around them. The family, the secondhand smoking. So if you have a good and smoking has clearly been a big factor for cardiovascular mortality and mortality. So I think, I think in a big sense, I think smoking is a bit no-no, and diet, everything in moderation, because I love my chocolates.
Lovely, thank you, Professor Vijay.
I think we should try to live with the bad habits of our patients. So what we can do probably is choose the patient and choose the procedure. As I mentioned, we know sweet eater is not suitable for restrictive type surgery. So maybe you find a sweet eater, maybe you avoid sleeve gastrectomy, choose the bypass. And for a smoker, you need to consider the margin ulcer and how you will deal with the consequence of smoking. So that's my comment. Yeah.
Thank you. Simon, do you have any comments?
And I think today debate is not fair, because smoking always said that evil, chocolate always said it's heaven for many people. But at the end of the day, this is the patient choice, as Vijay said. And my job is just to tell them what's the consequence of your choice, and that's what you take home afterwards. I think that's all we can do.
Thank you, Simon. Ken.
I guess we're dealing with addiction. So I would hope that I can turn my patient who is addicted to cigarette or chocolate to the addiction of calorie countings and exercise. So if they can turn the addiction to the other two, then I think we've done very well. But that's in the ideal world. So we can only try, I think.
Thank you very much. Thank you very much all for listening to us and for being here and joining us. All it takes is then for me to thank my honorable panelists and my dear speakers for their time. Thank you very much. We appreciate all your contributions. and we look forward to a face-to-face meeting in the very near future. Have a great time. Thank you very much, and goodbye.
Thank you all. Cheers.
Bye.
Thank you.
Bye.